Good evening to everybody. Welcome to all of you. So we are happy that Dr. Rajesh made the ARC more active with participation of young generation postgraduates. This is very useful thing for postgraduates and making the faculty also be active to follow them. Nice thing. Congratulations to Rajesh and all the ARC team members. We hope we continue the same throughout your period. So I hope there will be good discussion because senior teachers Dharmaraju, Tarakeswarao, Bharani Kumar Reddy, Yugandha Reddy, and all are there. We hope a nice discussion will be there. So let us start it.
Yeah, thank you very much for your kind words, VVL Narasimha Garu. This is our second ARC, APOS ARC webinar of short cases webinar. And we are happy that happy to have Dr. VVL Narasimha Garu as the moderator. Today we have as examiners Dr. B. Dharmaraju, is a professor of ophthalmology from NR Institute of Medical Sciences, Vishakhapatnam. The other examiner is Dr. K. Bharani Kumar Reddy Garu, who is a professor at Vishwabharati Medical College, Kurnool. We'll be presenting two cases today, case 3 and case 4. The first case is a Strach-Weber syndrome with exudative retinal detachment, choroidal detachment, and secondary glaucoma. This will be presented by Dr. K. Vaishnavi, first year DNB resident in ophthalmology from GGH Nandyal. Her mentor is Dr. G. Saujanya, assistant professor of ophthalmology, Government Medical College and GGH Nandyal. The second case is ectopia lentis, and this will be presented by Sheikh Shajia, the final year PG from Government Regional Eye Hospital in Kurnool. And her mentor is Dr. B. Yugandha Reddy, professor at Government Regional Eye Hospital at Kurnool. So it's over to our moderator, Dr. Narasimha Garu, to start the cases. So you're muted, sir. Please unmute.
So I think Vaishnavi is going to start or Shajia?
Vaishnavi.
So Dr. Vaishnavi, you please start your case presentation.
Shall I share the screen, sir?
Yes, please share your screen. For the time being, except for the examiners, all of us, let us mute.
Shall I start, sir?
Yeah, please start.
Yeah, good evening, everyone. I am Dr. K. Vaishnavi, first year DNB resident ophthalmology from GGH Nandyal. And today's my topic.
Just I am stopping for 1 minute. The first slide itself, ophthalmology spelling was wrong in 2 places. So being a postgraduate of ophthalmology, we are all will be very unhappy to write ophthalmology spelling like that. I ask all the undergraduates to write imposition if they write wrong. So the first page should not happen again. Please take it.
So
okay. Right.
Don't, it's a mistake, you should not commit again, as was told. But don't
Yes,
disheartened by this comment, but you should learn from this.
Yes, sir.
Yeah, you start, Dr. Vish. You can start.
Yes.
She has corrected it immediately.
Yeah, that's nice.
Go ahead,
Good evening,
Dr.
everyone.
Vaishnavi.
Yeah, good evening, everyone. I am Dr. K. Vaishnavi, first year DNB resident ophthalmology, GGH Nandyal. And today's my topic of presentation is a case of left-sided Strach-Weber syndrome with exudative retinal detachment and choroidal detachment associated with secondary glaucoma. My mentor for this topic is Dr. G. Saujanya, Assistant Professor, Government General Hospital, Nandyal. Professor and HOD is Dr. P. R. Nivedita, Ophthalmology, Government General Hospital, Nandyal. Chief complaints. A 45-year-old male patient came to Ophthal OPD with the chief complaints of sudden loss of vision in left eye for the past 2 months. A history of presenting illness. A loss of vision in left eye is sudden in onset and painless in onset, which was gradually progressive over the past 2 months, associated with redness, occasional watering, and pain. There were no complaints of floaters. There were no complaints of flashes of light or photophobia. There is no history of usage of any glasses, and there is no history of any ocular surgery, and no history of any trauma, no history of lifting heavy weights. Past history, there is no significant past ocular history. The patient is a known case of hypertension and on treatment for the past 4 years. And patient is not a known case of diabetes, asthma, seizures, coronary artery disease, or any stroke. Family history, there is no significant family history. In personal history, patient takes a mixed diet and appetite is normal. Sleep is unaltered or not disturbed. Bowel and bladder habits are unaltered. Clinical examination. In general examination, patient is conscious, cooperative, and oriented to time, place, and person. He is moderately built and nourished. There were no signs of palar, icterus, cyanosis, clubbing, lymphadenopathy, and pedal edema. On ocular examination, a patient head posture is midline. A globe is both a orthophoric. Facial symmetry, there is a left-sided hemifacial hypertrophy, portoine stain. Extraocular movements, both eyes bilaterally full and free. So we can see a portoine stain in the left side of the face extending from the eyebrows till the lower jaw in his face. A patient has a visual acuity of 6/9 in his right eye, which is not improving with pinhole, and hand movements in his left eye, which is not improving further. Orbital margins appears to be intact in right eye and appears to be intact in left eye. Eyebrows were normal in right eye, were normal in left eye. Eyelids were normal in right eye and normal in left eye. Eyelashes.
So you finish, Dr. Vaishnavi, you complete right eye first, then go to the left eye.
Okay, sir. So the patient has a visual acuity of 6/9, which is not improving in right eye, and orbital margins appears to be intact. Eyebrows, eyelids, and eyelashes were normal in the right eye. In right eye, conjunctiva is normal, cornea is clear, anterior chamber is open, and according to Von Herrig grading 3, class 3, and iris is normal in color and pattern. Pupil is normal in size and reactive to light. Lens, we can see nucleus sclerosis 1. Intraocular pressure was 17.3 mmHg at 11 a.m. measured at 11 a.m. with shears. Gonioscopy angle were open. So in left eye, visual acuity is hand movements presence which is not improving further, and orbital margins appears to be intact. Eyebrows were normal, eyelids were normal, eyelashes were normal. In conjunctiva, we have seen a dilated tortuous conjunctival blood vessels noted from 1 o'clock to 9 o'clock in position in a clockwise direction, where we can see a dilated tortuous vessels in the conjunctiva of the patient from 1 o'clock to 9 o'clock in a clockwise direction near the limbus. So cornea is clear, and anterior chamber VH Von Herrig grading 3 is noted. Iris is normal in color and pattern. Pupil size is normal in size and reactive to light. Lens, nucleus sclerosis 1 is noted. Intraocular pressure 24.4 mmHg noted at 11 a.m. measured with shears. On gonioscopy, angle is open and blood reflex is noted in the Schlemm's canal. So fundus examination, right eye, media is hazy due to NS1, nucleus sclerosis 1, and optic disc is normal in size and shape with discrete margins. Cup disc ratio is 0.3:1. Blood vessels were normal in caliber. Macula, foveal reflex present. In left eye, media is hazy due to NS1, and optic disc and cup disc ratio was not seen as it is obscured by retinal detachment. And blood vessels were normal in caliber and following the contour of retinal detachment. Macula, inferior exudative retinal detachment is seen extending from 3 o'clock to 9 o'clock position in clockwise, and macula is off. So we can see in right eye, we have seen a clear fundus with normal optic disc in shape and size with the cup disc ratio of 0.3:1, and blood vessels normal in caliber with foveal reflex. Whereas in left eye, where we cannot see the optic disc and the macula, which is covered by the retinal detachment, which is extending from 3 o'clock to 9 o'clock in position in clockwise direction. So B scan,
Just wait
right eye.
here, doctor. Okay,
Sir.
complete your B scan. You want to tell the B scan.
Yeah, B scan, right eye is normal. In left eye, we have seen a choroidal hemangioma, choroidal kissing sign, choroidal detachment, and retinal detachment. So these are the pictures of B scan where we can see a choroidal kissing sign in this picture. Choroidal kissing sign in this picture. And the choroidal hemangioma, the hyperechogenicity we have noted in this picture. So we can see a retinal detachment detaching from the margins of optic disc on either side. And again the choroidal detachment where it is not reaching the optic disc margins. Okay, a systemic examination. Other systemic examination appears to be normal. We have planned for the
Just
MRI bed.
wait here. Okay. So basing on the clinical findings, what is your clinical provisional diagnosis? Your MRI brain, everything is not willing. Okay.
Yeah.
What is your provisional
Patient,
diagnosis?
sir. So patient is a known case of Sturge-Weber syndrome where we have seen a Potoin stain.
You're diagnosing a case of Sturge-Weber. Patient came already known diagnosed as Sturge-Weber.
No, sir.
Then your diagnosis Sturge-Weber.
Sturge-Weber syndrome with the left-sided diffuse choroidal hemangioma with exudative retinal detachment and choroidal detachment with secondary glaucoma.
Okay, doctor. Let us start from the case sheet. First, we talk about what are the defects in the case sheet. What are the things that we have to correct? Okay. Go back to the first slide.
Sir, with chair permission, my suggestion, one suggestion is there, sir.
Yeah.
Hello?
Yeah, definitely.
At PG level, she's telling that it is a retinal detachment, but not describe anything about retinal detachment.
That's what I'm going to correct.
Fundus description.
No, I'm going to correct so many points in this case sheet. Just I want that's the reason I allowed her to talk. Then I'll correct everything.
Okay.
The first thing, doctor, the chief complaint, this is not the way you just write like this. Chief complaint is patient has come to the department with a sudden loss of vision. So your complaint should be sudden loss of vision in the left eye, 2 months duration. You need not mention something like, anyway you give in the name, age, sex, occupation, everything, no? I think that slide was missing. Okay. Is there a slide where it is age, sex, of course, the name should not be mentioned. Age, sex, occupation, so slide is missing in the case sheet. And the chief complaint should be 1 or 2 lines, isn't it?
Yes, sir.
You are not, as a postgrad, you are not supposed to write like this. Go to the next slide. Sudden loss of vision. What do you mean by gradually progressing? Is visual acuity is deteriorating over a period of time?
Yes, sir. Visual acuity is
Stable?
deteriorating over a period of
At what time when he presented to the department, what is his visual acuity and what is present visual acuity?
So, the time he presented to the OPD, visual acuity is hand movements plus. But he had previous reports where he 2 months back with
No,
the
you should
visual
not.
acuity of
Okay.
with the visual acuity of 660 in other hospital.
Okay, that comes from the past history. In the present history, you should not mention that one. Past history, you can mention about that. And next thing is total splashes. Did he inquire about his, because Sturge-Weber syndrome is something like involving the CNS, eyes and skin, isn't it?
Yes, sir. I have asked about present any seizures or stroke-like symptoms in the past history.
But is there any mention about seizures?
Yes, in the past history.
No. Okay, seizures of. Okay, so go to the previous slide. History should cover all these points. See, as far as the neurological symptoms are concerned, what are things you are going to ask?
So any history of seizures in the past or mainly in the childhood period?
One is
Or
seizures.
any stroke-like, sir?
Okay, go on. What are all the important points we want to elicit from the history as far as the CNS is concerned?
Any history of seizures, any history of hemiparesis?
Hemiparesis. Next.
Any history of stroke-like symptoms?
Very good. Next. Hemianopsia, isn't it? Homonymous hemianopsia. Patient will get homonymous hemianopsia. That means you
Yes,
can
sir.
ask the patient whether he is able to see one side objects are seen or not, right or left. Right homonymous, left homonymous. Like that, you need
Yes.
to ask about that. Those things which are related to the neurological signs, okay, symptoms. Okay.
Having any difficulty while walking and especially dashing while that particular history you have to inquire regarding the hemianopia.
Yes.
Yes. So it is adult onset, isn't it? It's not a childhood. Okay. Infantile type, not. Next slide. Next. The patient is known hypertensive for the last 4 years.
Yes, sir.
Age of the patient is 45 years. 45 years, no? Okay.
45 years. Sir.
Yeah. Next slide. Skip. Yeah, it is. Post slide.
With the history of hemifacial hypertrophy, what you have seen, what further things you can expect in the brain?
Leptomeningeal angiomas might occur, which lead to seizures. In MRI, we can see tram track appearance.
MRI or CT, which one is better?
CT.
CT. Calcification will
It is
become very
calcification, so we can see better in CT.
Especially the prognosis will be very poor, multiple system involvement will be there once it is a facial hypertrophy is there. But usually common presentation is usually unilateral, that will be confined to the distribution of ophthalmic nerve. Then the picture will be very mild. In such a case, we will expect a severe findings, especially brain involvement is almost a possibility. Right. Go ahead.
Next. So basing on this picture of wait here, the picture. Basing on the picture, which V1, V2 or V3, which one is involved here?
V2 and V3 are involved.
Yeah. So that's important. Commonly we get V1.
Yes, sir.
That is, yeah. Next slide. still your IOP recording an IOP, still you're using a Shear tonometer. Nobody is using Shear tonometer nowadays. That too in a push. Nobody is using. When you are
Actually,
recording an
now-
intraocular pressure, you have to mention it is a GAT, isn't it? And
Yes,
particularly, you
sir.
have to mention the timing. What time you are recording an intraocular pressure with the Goldman apnation tonometer. Your IOP should be mentioned as IOP GAT at 11 a.m., 11 p.m., 11, 12 p.m., something like that, you know. It
Yes,
is,
sir.
of course, you mentioned about 11 a.m., but the recording of 17.3, these are all outdated. Nobody mentions about why you should not mention here.
Actually, in our department, the SHIORD is the one which is working on GAT is not working properly. So
Not
we
working. That was an excuse, but we're not supposed to mention, you know, this reason
yes,
why,
sir.
isn't it? What do you expect in gonioscopy, adult gonioscopy, both eyes? What do you expect in the gonioscopy in the left eye? You have seen blood in the stem canal. What do you expect in this patient?
Raised episcleral venous pressure.
And you don't see raised episcleral venous pressure in the, what are the things that you look at the anatomically, what you look there?
Blood reflexes in
Did you
the
inquire whether the stain is present since childhood or it must be in the birthmark, you know? Birthmark, you know?
yes,
Port vein stain, port vein birthmark must be present in the childhood. How do you
it
discern?
has a
How about
presentation in
the
childhood.
intraocular is increased? Is intraocular infantile onset or is it late
It is
onset?
an adult onset.
How to tell it
Sir.
is an adult onset? It's not a infantile onset.
Patient, so in infantile onset, the patient will have complaints from the childhood. And
What do you say?
in gonioscopy, we can see angle closure, angle
No.
anomalies will be
What
seen.
are the features to tell it's an infantile onset of glaucoma?
Okay. So we can see angle closure and ophthalmos in infantile stage.
The corneal diameter, no? See, look at the corneal
Yes, sir.
diameter. It's more than corneal diameter, and of course, you see the other findings of ophthalmos, isn't it? Abstray, everything.
Yes, sir.
The not seen is the corneal diameter is normal. It definitely the late onset of secondary glaucoma, isn't
Yes,
it?
sir. Yes, sir.
So
See,
then
what
you
is the
don't find any anatomical changes in the angle.
What is the
Sir?
cause for raised pressure if the same patient has presented at a quite younger age? That means before 2 to 3 years. And what will be the
That
cause
might,
for raised pressure presented at
yes,
this
that
age?
might be because of angle anomalies.
Angle anomalies if he has presented at a very young age.
Very younger age.
Now what may be the cause?
No, it
Suppose
is a
very earlier
mainly due
pressures.
to raised episcleral venous pressure.
Now what is the cause for raised pressure now?
It is conjunctival and episcleral hemangiomas leading to raising episcleral venous pressure.
Episcleral raised pressure that is responsible for, especially in old age, whenever Sturge-Weber syndrome presents, that may be the cause.
Yes,
It is presenting for the first time. If earlier IOPs were normal, and if it is recorded for the first time, raised episcleral venous is the responsible for the so-called secondary glaucoma. Right.
yes, sir.
Got it.
Is there any third cause is there? Sir is already mentioned about 2 causes. Is there another possibility of having a raised IOP for the
Raised
but there
IOP.
is a ciliary body hemangioma is there. Hemangiomas can occur anywhere
Yes, sir.
in the
Ciliary
body or in
happens
the
and
eye
also.
also, isn't it?
Yes, sir.
So what happens? There is a ciliary body hemangioma is also there, for example. There will be hypersecretion of the aqueous, increased secretion.
Increases secretion.
So that could be also a probable cause, isn't it?
Yes,
Okay.
sir.
Yeah.
Fourth rare presentation is it can rarely it is presented as acute angle closure glaucoma. Whenever there is a circumscribed or diffuse hemangioma, that also has been reported earlier. So that's a very rare presentation. So the total four mechanisms are there: hypersecretory, rarely acute angle closure glaucoma, and the common mesodermal dysgenesis if it presents in the young age, and old age is like this. raised episkeletal venous pressure. So all these four will account for raised pressure.
Yes, sir.
Next slide. Next slide. So this is what Dr. Tarkeswar sir is mentioning about that. So a 43 years patient, you call it as a sclerosis, multiple sclerosis, is a senile cataract. 45 years
Sir?
age, you call it as a senility.
No, sir.
Then it's not a senile
It is not
cataract.
senile cataract.
Then
Pre-senile.
any cataract secondary intraocular disease supposed to be a complicated cataract,
Yes, sir.
isn't it? Also,
Yes.
metabolic disorders are there. That's a different one. And don't mention in younger patients senile cataract. Okay.
Yes, sir.
And OD, obscure RD is that. Then when you're describing a RD, there is a rigorousness, we have a tractional and a bullous RD. It is a bullous RD, isn't it?
Yes, sir.
Exudative RD. What is the description of exudative RD?
Dr. Dharmaraju,
Sir.
it is already 8:27.
Yeah. We are almost 3 minutes.
We have
only.
second case also. So
Yes.
conclude within 5 or 6 minutes so that the other candidates also will have
Yeah,
sufficient
true.
time. Okay.
Okay, doctor, you have to mention about the characteristics of a bullous RD, serous serous retinal detachment. So you should
Yes,
mention
sir.
about concave, convex, something like that, Go to the
It
next
is a
slide.
convex shaped RD with no folds in it and in a
Okay,
dome
go to
shape.
next slide. Time is short because we have to talk about the management and treatment.
Yes.
Okay, next slide. And when you talk about the base scan, you're supposed to talk about the echogenicity, hyperechogenicity or something like that. You should not mention something like a hemangioma, isn't it?
Yes.
So the pictures echogenicity you have to mention about and of course choroidal kissing. And the next one is okay. Next slide. Next. So when you come to the diagnosis, Sturge-Weber syndrome, we have different classification systems are there: type 1, type 2, type 3. Just go through the
Roche
literature.
classification. Yes, sir.
Is it complete or incomplete?
Sir?
You have to read about
Without
something literature about the
yes, sir.
Sturge-Weber. We have a
I might have
complete.
mentioned the type 2 type.
You know that type 1, type 2, type 3?
Yes, sir. In Roche, according to Roche scale, type 1 is a
Yeah,
patient.
you know that. That's very good.
Yes, sir.
Time is short. So how will you manage this patient? What are the machines you do?
Okay. With the patient is having a port wine stain, which we can be managed with a pulse dye laser. And
No, which is most
for ocular
important?
manifestation,
What is the most important thing you have to do first?
we have to manage the secondary glaucoma and the
Yeah, that is
choroidal
more important,
detachment.
isn't it? Yes.
So for secondary glaucoma, we can use a topical drugs like beta blockers, alpha agonists, and miotics, which are
TGN
more.
locks are indicated? Is TGN locks are indicated in this case?
Sir?
TGN locks are indicated in this case?
No.
Why?
Because they will increase our UVF scleral output, which are less useful in this condition.
Yes,
We need to
exactly.
decrease aqueous.
So how to manage your choroidal hemangioma and exudative RD?
Choroidal hemangioma and exudative RD, we can do photodynamic therapy or proton beam therapy. Stereotactic radiation.
Okay.
So what are the difficulties of managing glaucoma in a Sturge-Weber syndrome compared to other open angle glaucomas? What special difficulties it poses?
So maintaining pressures even while using the drugs is a difficult condition where we can't
So the medical
control the
treatment will not be very much prolonged.
Yes, sir. We can't.
They will not work for a longer time. So then we have to resort to some sort of surgeries. Even surgeries in the Sturge-Weber syndrome will be a problem associated with a lot of complications.
Complications are more.
Reason why we go for a GDD, glaucoma drainage device is also needed here.
We can go for glaucoma drainage devices to
Something like a refractory glaucoma. Because
trabeculectomy.
sometimes
Even glaucoma drainage device also poses a lot of problems in Sturge-Weber syndrome cases like hemorrhage,
it is refractory.
exclusion, etc. Usually that will be a failure in Sturge-Weber syndrome. In the best nowadays, recently what they suggest is a trabeculectomy with use of express implant, especially because we are not supposed to do iridectomy, especially in a conventional trabeculectomy, we have to do iridectomy. Whereas in these particular cases, there will be a lot of bleeding if we try to do an iridectomy. So if
Yes,
we
sir, because of
use the
hemangiomas.
implant, we can avoid that iridectomy. That is the latest surgical procedure that is suggested for this Sturge-Weber syndrome with the minimal complications.
I think we can go for the next case, sir. When you have a combination of both angle structures abnormalities as well as late onset glaucoma, trabeculotomy combined with trabeculectomy, and sir said nowadays we got extra strands as others are there, which we can use. Sir, shall we?
Vaishnavi, one question. Vaishnavi, what is the cause for RD in this case?
It is a choroidal hemangioma. There will be a multiple leaky vessels leading to fluid seeping in the subretinal space and suprachoroidal space, resulting in choroidal detachment, retinal detachment. Even blood retinal barrier is compromised in this case.
Usually, it is a circumscribed hemangioma that is responsible for RD, whereas a diffuse hemangioma that is responsible for a choroidal detachment. Especially if it involves the posterior cone, there will be what will happen is there will be overlying retinal degeneration. Ultimately,
Yes.
defect will form. Then
Start degeneration.
it will form. So circumscribed hemangiomas usually they will lead to RD. A diffuse will lead to exudative choroidal detachment.
Yes.
Moreover, the RP is an atrophic. Here, RP is also atrophic. The retinal start degeneration will be there. So it's not rewarding. Most of the times, the RD will be there.
Okay.
Shall we switch on to the next case, sir?
Yeah.
Meanwhile, sir, I'm Dr. Nivedita. We have planned though we don't have this proton beam therapy, at Kurnool, photon beam therapy is available. Even that is effective in case of brain hemangiomas. And so we wanted to plan, but the patient is not willing actually. We wanted to plan the photon beam therapy. So probably if the patient is willing, we'll try this.
It's brachytherapy, external beam radiation.
Yes. The radiation retinopathy is one problem. That's why people are shifting to PDT, photodynamic therapy.
Yes.
Yeah, we can go to the second case, Dr. Shajia.
Thank you, sir.
Yeah.
Dr. Vaishnavi, you should stop sharing. Only
Yes,
then,
sir. I'll stop
yes.
sharing.
Stop sharing. Yeah. Now, Dr. Sheikh Shajia, can you share? Start your sharing. Good effort, Dr. Vaishnavi. Being a first year DNB resident, I should congratulate you and your mentor, Dr. Saujanya. And special thanks to Dr. Nivedita for pushing the first year postgraduate to present in a webinar like this. and facing the stalwart examiners. So if you're ready, Dr. Sheikh Shazia, you can start sharing your screen.
Thank you, sir.
Thank you, sir.
Thank you.
Good evening, madams and sirs. Good evening, sirs and madams. I'll start presenting my case. My name is Dr. Sheikh Shazia. I'm third year postgraduate from JREH Karnool. I'm presenting this case under guidance of our professor, Dr. Yugandhar Reddy sir, MS. A 45-year-old female patient named
Activate the slideshow in your screen. Activate the slideshow. Bottom right, yeah. Yes. Activate that.
A
Yeah, now you can-
45-year-old female patient named Shiromani. She is the resident of Karnool, tailor by occupation, presented with chief complaints of diminution of vision in both eyes since 3 years. History of presenting illness. Patient apparently normal 3 years back. Then she developed diminution of vision in both eyes, which is insidious in onset, gradually progressive and painless. There is no history of diplopia, no history of redness, photophobia, glare, floaters and flashes, no history of ocular trauma, no history of usage of any topical medications, no history of joint pains and laxity of joints, no history of limited joint mobility, no history of palpitations or dyspnea, no history of developmental delay, history of irregular use of glasses since 3 years. Past history. She is not a known hypertensive, diabetic, coronary artery disease, CVA, TB, asthma, epilepsy. Patient has not been screened for any congenital syndromes in the past. She is not a diagnosed case of any collagen vascular disorders. Treatment history, nil significant. Family history, nil significant. No history of consanguinity, mental retardation, or premature deaths in the family. General examination. Patient conscious, coherent, well-oriented to time, place, and person. She is moderately built and nourished. No pallor, icterus, cyanosis, clubbing, and lymphadenopathy. Her vitals are stable. BP 128 mm of Hg, pulse 72 beats per minute. CNS, no focal neurological deficits. CVS, S1, S2 head. Respiratory system, bilateral air entry present. Per abdomen soft. Ocular examination, head posture normal. Facial symmetry, bilateral symmetrical. Right eye examination, visual acuity, counting finger 2 meters, not improving further. Orbital margins are palpable, continuous, and non-tender. Eyelids are normal. Rhoplast is negative. Conjunctiva normal. Cornea, arcus senilis, horizontal diameter of cornea is 11.5 mm. Vertical diameter is 10.5 mm. Sclera is normal. AC shallow. Van Herrick's grading 2. No cells, flare, vitreous in the anterior chamber noted. Iris is normal color, normal pattern. Pupil normal size reacting to light. Lens undilated pupil. Phacodonesis noted. Lens subluxated cataractus lens in supraonasal direction. Extend from 5 to 10 o'clock hours position. Jonules are stretched. No pigments or exfoliation noted. This is the diagram of right eye showing. This is the image of right eye showing jonular dehiscence from 5 o'clock to 10 o'clock position with supraonasal subluxation of the lens. Extraocular movements are full in free in all gauges. IOP is 14.6 millimeter of Hg. Left eye, counting finger 3 meter, not improving further. Orbital margins are palpable, continuous, and non-tender. Eyelids are normal. Rhoplast test negative. Conjunctiva normal. Cornea arcus senilis with horizontal diameter of 11.5 mm and vertical 10.5 mm. Sclera is normal. Anterior chamber shallow. VH2. No cells flare noted in the vitreous noted in the anterior chamber. Iris is normal color, normal pattern. Pupil normal size reacting to light. Lens is in undilated pupil. Phacodonesis was noted. Subluxated cataractus lenses in supraonasal direction. Jonular dehiscence extending from 4 to 7 o'clock position. Jonules are stretched. No pigments or exfoliation noted. This is the left eye image showing subluxation of cataractus lens from 4 to 7 o'clock position. Extraocular movements are free and full in all gauges. IOP is 12.2 mm of Hg, which yours is noted. Fundus examination, both eye fundal glow not appreciated due to dense cataractus changes. Investigations, keratometry, K1, K2 readings are 41 point in right eye, 44.25, and K2 readings are 46 degrees at 46 degrees at 65 degrees. In left eye, K1 readings are 45 and K2 is 46.75 at 90 degrees. On a scan, axial length is 21.17 mm in right eye with IOL power of 26 diopters. Left eye 21.4 mm with IOL power of 24.50 diopters. Retinoscopy, both eye reflex not clearly appreciated. Gonioscopy performed with 3-meter gonioscope. In right eye, ciliary body band seen in all quadrants, Shafer grade 4. In left eye, ciliary body band seen in all quadrants, Shafer grade 4. In B scan, bilateral short axial length noted with normal retina choroidal scleral complex. Systemic investigations, ECG is normal, 2D echo normal, urine homocysteine levels were negative, plasma homocysteine levels are normal, VDRL test is negative, chest X-ray is normal, Montux negative. My provisional diagnosis is both eye subluxated cataractous lens due to spontaneous etiology. Surgical approach, patient has underwent right eye extracapsular cataract extraction and during surgery vitreous prolapse has occurred. Open sky vitrectomy done and left aphakic. On first post-operative visit, eye is quiet with vision improving to 624 with plus 13 diopters lens. Further plan of management, spectacle correction or secondary implantation of eye. Thank you.
Before you start discussion, you show the first slide, some basic second. Here, no, before, back. Chief complaint, diminution of vision. What is the spelling of diminution of vision? As a postgraduate, you should not write such basic mistakes. Diminution, word is not there. Diminution, N-U-T-I-O-N, diminution of vision. And somewhere you have written patient is conscious. There also there is a spelling mistake. So as postgraduate, we should not commit the basic mistakes. I will get all the mistakes, basic mistakes. I will get it because Gopal Raju sir also gives me all proofreading. So for the tablet I developed, I think. So don't do such mistakes.
Okay,
And one doubt before you start discussion, you have mentioned anterior chambers are shallow and there is subluxation in both eyes. Are you sure the anterior chambers are shallow?
Yes, sir. Anterior chambers are shallow.
Okay. Let the examiner start the discussion. Okay.
So to which category you want to fit the case? As far as India?
As it will not fit into congenital causes and acquired causes. We have ruled out so many causes, sir. So I will put in this idiopathic subluxation of lens. Spontaneous subluxation.
So what are the various ocular causes that can precipitate this subluxation?
Yes, sir. High myopia, pseudo exfoliation, increased corneal diameter cases, and Axenfeld Rieger's anomalies where the prominent Schwalbe's line will be present. Retinitis pigmentosa.
Any history of any inflammatory changes are there?
Yes.
Any history?
Yes, sir. No, there is no complaints of redness, photophobia as mentioned by the patient, sir. Hypermature cataract, retinitis pigmentosa ruled out, sir.
So what are the various? If it is here it is a cataractous lens or a clear lens?
It's a cataractous lens, sir.
Suppose if it is a clear lens, what are the various options of managing?
If it is a clear lens, based on the symptoms of the patient, if the patient is asymptomatic, we'll ask the patient for regular follow-up, sir. If the patient is symptomatic, we'll make first refraction. If with best correction to aphakic or phakic zones, we'll prescribe the spectacles, sir, or contact lenses. If the patient is not accepting the glasses, then we go for further surgical management. Not improving further, we'll go for surgical management.
So how do you grade your, how do you, sir, you completed?
No, go ahead, sir.
Doctor, you have so idiopathic you said, isn't it?
Yes, sir.
Idiopathic you said.
Yes.
Could it be lens induced? It could be the stage of maturity because you are not able to see the posterior segment. When you
Yes,
see
sir.
the bone segments, the cataract may be going from the maturity they happen with the stage, isn't it? Mature stage also there can be possibilities the genre diagnosis can occur, isn't it?
But
So
there
could
is
be
no
lens
rise
induced,
to intraocular
isn't it?
pressure.
Lens
But
probable
there is
cause. The maturity of the lens may be the probable cause for this case, isn't it? So you said the genre dehiscence is there.
yes, sir.
So basing on that, which grade you put?
From
Mild, moderate, severe, advanced. You have different grades of.
moderate grade, sir. Right?
You know that
Moderate grade.
grading of this thing, you know?
Based on the
Mild,
clock hours, sir. Based on
clock
clock
hours.
hours, will grade, sir. If less than 3 clock hours, mild. 3 to 6 clock hours, moderate. 6 to 9 clock hours, severe. More than 9 clock hours,
Yeah, yeah.
very
So
severe.
he's asking, basing on this, the genre distance of clock hours, mild,
Yes, sir.
moderate, severe,
Yes.
advanced. Yeah?
Yes.
Do you have any specific management plans? Do you have?
Yes, sir. As the lens is cataractus,
Is
we
a
can go
cataract
for
lens. You have a
yes,
clear
sir.
lens and cataract lens, isn't it?
Cataractus
When
means
it
we
comes to the
can go
management.
for capsular tension rings with surgery.
No, no. I'm asking about 3 clock hours of genre distance is there in a cataract lens.
Yes,
What
sir.
is your management? 3 to 4, 3 to 6,
We
6
can
to 9,
manually,
above 9.
we can use capsular tension rings, sir. We can use capsular tension rings if 3 to 4 clock hours.
3 clock hours. What is the type of management?
Or
3 to
we can use posterior chamber intraocular lens with the haptic facing towards the weakness of the journal cells.
okay.
The next bit is
What are the capsular tension rings? What they do?
In capsular tension rings, they will spread the jonular tension equally in all directions, thereby it prevent further subluxation of lens, and it will prevent further.
Functions right? It provides a stability during surgery.
It buttresses the areas of weakness, and it provides equal jonular tension in all directions, including in subluxated positions.
I should know that the centration also is important, no? IOL centration also taken
Yes,
care.
sir. Centration of IOL is.
What about capsular tension segments? You have capsular tension segments out there, isn't it?
Yes, sir. Capsular tension
What is the
segment,
role
like
in
a
this
mud
case?
segment, will fix this capsular bag with the sclera, so it can prevent further subluxation of the lens. Mostly, we can use them in progressive jonulopathies, like in case of PXF, all those cases we can use.
There's more than 9 clock
More
hours.
than 9, we can go for intracapsular cataract extraction with scleral fixated IOL or iris claw IOLs or anterior chamber IOLs we can use.
Okay. Go back to your case sheet. A few corrections you need.
Yes, sir.
Few corrections you need. Go to the next slide. And usually in subluxated dislocated lenses, you get a monocular diplopia, isn't it?
Yes, sir.
So you can specifically mention monocular diplopia, isn't it? We have a binocular monocular diplopia,
Yes, sir.
and it's a trauma. Next slide.
Yes.
Next.
In therapy.
So you have mentioned about the trichodonosis, isn't it?
Yes, sir.
And you said the iris is normal color, normal pattern.
Yes,
And
sir.
there's no support to the iris. The lens is not supported by so what about the iris? Do you find iridonosis?
Iridonosis, yes, sir.
You don't have iridonosis.
But it is not noted.
Usually, see, when there's a support, when you know support to the lens are this subluxated, usually, most often you get hydrodonosis, isn't it?
Yes,
Because at least one segment, and moreover, one thing is, yeah, one more point you have to look for this is the AC depth also. When subluxation occurs, irregular depth can also be there,
yes, sir.
isn't it? Irregular depth of the AC can also be there. These are the things which maybe may not be, but usually, most often you see those conditions, you know. And the people with such, and is there any witches? There's a donor distance of about 5 to 10 clock hours.
Yes, sir.
What do you see in the witches? What do you want to look for in the witches cavity? Anterior chamber.
We can see vitreous in the anterior chamber, sir.
Yeah, that
Due
also
to
is
so
very
much of
important thing. You have to
subluxation.
look for those things,
Yes, sir.
isn't it?
Yes, sir.
And during intraoperative surgery, can
Yes,
you
sir.
make out that while you are doing surgery, can you
Yes,
make out this is almost going into mature to hypermature stage? Can
yes,
you
sir.
make out any signs which will give a clue when you do the rexis, when he is going runaway rexis? Is there any clinical signs that will tell you it is going on to the equatorial region or going beyond the equatorial region? Any
There will be
signs that
altered
can tell you?
fundal glow will be noted, sir. Altered fundal glow will be noted.
Not that. I'm talking about the intraoperative surgery.
Yes, sir.
Can it give you, because most of the times, you know, these cases, when you're doing rexis, even though you implant, that's the reason why you are taking care of capsular tensioning for other things, isn't it?
Anterior chamber depth will be varied.
Yeah.
There will be
Have you heard of this flap mobility sign? Flap mobility sign?
yes, sir.
Can you tell me about that?
Extension of the capsular axis will cause the iris to be very tremulousness of the iris.
Not exactly iris. The flap which is doing, you know, you do a capsular flap, which is a flap, isn't it? Fluttering a flap and then it is averted or inverted. Based on that, you can know that the rexis, runaway rexis margin has gone only up to the equatorial or beyond the equatorial. Just read about that. There's a sentence called flap mobility sign. That's a very important clinical sign during intraoperative surgery. So basing on that, whether to put an IOL or take care of this, anyway, you are taking care of capsular CTRs and capsular tension signals and all these things. And they're all very, very important. Okay. So,
how to select CTRs? Or any criteria to select a particular CTRs? Are all CTRs the same or different sizes are available?
Different sizes are available, sir. Based on the axial length of the patient, we can select the CTR, sir. If the axial length is between the 24 to 28, we'll select the number 13 size CTR, sir. If the axial length is less than 24 mm, we can select the size 12, sir, 12 mm, which is compresses to 10 mm.
What are the indications for Sioni ring?
Sir, yes, sir. If the clock hours are more than 4 clock hours of jonular dehiscence, we can use the Sioni rings, which are modified CTR rings, which is single loop and double loop Sioni rings based on the clock hours of jonular dehiscence we'll use.
in your case, do you like to take which CTR ring you select? Basing on your parameters, you have seen that parameters.
Yes, sir. Single loop Sioni ring will select, sir. 5 clock hours jonular dehiscence.
Yeah, just 5 and 10 clock hours.
Yes.
So which area of the capsule you select to enter the CTR?
In the areas of prominent jonules, we should never do from the areas of jonular weakness.
Yeah, we have 5 more minutes. Please try to conclude.
She is doing a good job. All she needs is to do all the surgery. That's all. She knows all the theory.
Doctor, what is the role of flax in your case? Subluxated lenses. Role of flax.
Sir, flax, sir. It will do proper capsulorhexis, sir. In flax surgery, the capsulorhexis will be clear and good, sir. It will do nucleotomy, sir, so that it will not extend further journal or stretching.
Yeah, because
It will
the
create.
senior surgeons can tell Rajesh.
I'll add to this. See, flax is very theoretically, we can say that because there is a zonal dialysis, we can do a good capsulorhexis using the laser. But what happens is if the lens is tilted, sometimes we don't get the laser uniformly throughout the circle because of the tilt. Intraoperative OCT is there that will help to what do you say, monitor and calculate the angle of subluxation, and it will help to do the laser. But practically, while doing those cases, what we have noticed is that the capsulotomy will be incomplete in certain segments where the tilt is more. But majority of the capsulotomy happens, and that smaller part we can complete it with the manually, and we will be more successful in dealing with these cases, because most of the time when we're doing the rexes, uh, there'll be faults on the capsule, and we'll be pulling on the zonules. That pull on the zonules is reduced when you're using flax, when you're using the laser. That's definitely useful, but it is not the one and only solution. And be aware that there are certain limitations also when doing the flax in a tilted lens, basically.
Yeah, yes, true.
Yeah.
Sir, ఈ కేసులో ECC possible without any capsular CTR ring?
You're asking me?
Yes, I mean, not you, sir. The PG.
Okay.
Sir, we have done ECCE.
Yeah, without any capsular tension ring,
Capsular
you had done ECCE. Is it possible?
As capsular tension rings are not available, we plan to keep the IOL, sir, but due to vitreous prolapse and all, we have not get, sir. We left up
So
it.
finally, it is ended in ICC.
ECCE only we have done, sir, with the PC rupture.
Have you carefully seen for any pseudo exfoliation?
Sir, no, sir.
No, it's very important, such cases where you don't, your homocysteine levels are normal, other things are normal. Of course, not thorough evaluation of all of these syndromes we haven't done, but in most of the cases, look for the pseudo exfoliation. Most of the times,
There is
that
no
will
pseudo
cause the
exfoliative
jaundice.
material around the pupillary zone or in
One final question to you.
Yes.
Your homocysteine levels are negative. If they are positive,
Yes, sir.
what is the precaution you take while you're doing?
Sir, during surgery, we have to keep as it is an vaso-occlusive. It will cause the thrombosis, sir. So we have to take care. We have to give anticoagulants prior to anesthesia to prevent vaso-occlusive.
Thromboembolic phenomenon.
Thromboembolic phenomenon.
Thromboembolic phenomenon. Homocystinuria is common. Look for the transformation defects other things also. There are congenital varieties are there, no?
Yes, sir.
Those look for the transformation defects other things.
Yes.
Platelet aggregation that is responsible for the thromboembolism.
Yes.
Especially there will be a platelet aggregation that is responsible for the thromboembolism whenever they undergo the surgery under general anesthesia.
Yes, sir. We have to give antiplatelets prior to surgery to prevent thromboembolic events.
Good, Doctor.
Yeah, it was a good case presentation. So regarding the management, when you don't have the backup of CTRs, in such cases, the same sitting, you could try removal of the lens just with Vectis, do proper vitrectomy, either iris claw lens or SFIOL at the same sitting, maybe the best in the situation which will be available in government setup. That is the easy thing. If we can plan, because our patients may not come again. Nowadays, nobody is giving FAQ classes. If you give FAQ classes, it will reflect as bad. So it was in our postgraduate days only, FAQ classes.
And in this case, sir, other eye also requires same thing.
Yeah. You have to plan, at least in the other eye.
We can, even now we can plan, sir. We can plan for a secondary vitrectomy with the secondary IOL implantation.
No, that is where we are government doctors and Rajesh is private doctor. They score over us by doing
No, sir.
same sitting.
We have done many secondary IOLs, sir.
No.
Vitrectomy.
If we do it in the same sitting, we can be equal with Rajesh. That's what I am saying. Why? What, Bharani sir? We can plan the same sitting. Do vitrectomy, SFIOL, iris claw lens, same sitting. Why second sitting? That's.
Sir, VBL sir must have changed. ఇలా చేద్దాం సార్ అంటే నో ఇలాగే చేయాలి అంతే.
No.
When I was in Kurnool, I used to do, sir. When I was in Kurnool, I used to do.
Yeah, good.
So now, because I got transferred,
yeah,
usually we are not doing. So later in the second sitting, we are doing.
Yeah. New hospitals, new colleges, this setup, it will take some more time to have vitrectomy. All these additional things, small things also will be difficult in the new setup. So we have to, and I congratulate not only the postgraduates, all the teachers who made them present good cases. And it appears as if 1 hour is not enough for 2 cases. If it is one case, it will be better, but to cover majority of the postgraduates, we have to do 2 cases. It was a nice discussion. Thanks to Dr. Bharani Kumar Reddy and Dr. Dharmaraju and all the ARC team and the team leader Rajesh for excellent.
Thank you, sir. We have specifically kept it as half an hour because these are short cases. Okay. Even in the exam, these cases will be, we are selecting cases only those cases that will be as short cases, and the discussion should stop at 20 minutes. Actually,
have to plan accordingly, sir. Plan accordingly.
Usually in short cases, we will take a brief history. That's all. Our clinical examination is more.
Yeah.
Ocular findings will be take more, and only history will be small.
Answer more on discussion.
We directly go into the local examination findings.
Shajia, I think I know each the negative history that you have given, every single point has a meaning in this particular case. But since it's a short case, I think you should stick to the positive findings.
That is better.
So that your presentation is quicker.
Yes,
we can have more discussion.
Yeah, we can have more discussion. I know that every single point that you said, no history of joint laxity, no history of congenital disease, all these are very important in this case. That the examiners will ask you, did you take the history of joint laxity? Then they'll ask you, why did you take that history? It can go that way also. I think I should congratulate Dr. Yugandhar Reddy for training his postgraduate so well. And special thanks to Dr. Kailan Razu, who has pushed all these people, both Dr. Yugandhar Reddy and Dr. Shajia, to present this case. And the first case, the credit goes to Dr. Nivedita Madam, who has pushed Dr. Saujanya and Dr. Vaishnavi to present that those first case properly. And the first case, the postgraduate is a first-year postgraduate. And for a first-year postgraduate, I think she has done a good job. What do you say, Dr. Narasimha Garu?
Definitely. First-year postgraduate presenting in a state forum is excellent. We should special congrats to the postgraduate and Madam Professor. Both.
Thank you, sir.
Very happy to see you all, sir. Kurnool alumni, all are my teachers, sir. All are my PG teachers. Very glad to see Dr. Bharani Kumar Reddy, sir, after a long time. And now my younger son is a sir student at VBMC. Yes, Dr. Nivedita Madam, Dr. Yugandhar Reddy, sir, all are my teachers, sir, when I was doing PG at REH Kurnool. Very happy to see you, Madam, sirs, on this occasion. And congratulations, Dr. Vaishnavi, Dr. Shazia.
Thank you, Sarisha, for
Yeah,
remembering us.
you did a very good job. And all the examiners, they did very excellent, sir. Very useful for the PGs. Thank you all.
Thank you, ma'am. Thank you.
Very good discussion, sir. Thank you,
Thank
sir.
you.
We thoroughly enjoyed, and also regarding your points, we'll note them and we'll rectify them, sir.
The purpose
Case sheet
is
writing.
these practical things in discussion only the postgraduates will remember. It is useful for their examination. That is definitely. Always, if we discuss with our postgraduates, they know only fixed questions from us. If the examiners change, they will know from other areas also. That is
Yes,
always
so
good
that's the
thing.
reason why we have started this, the
This is
ARC team.
exactly, this is exactly
Yeah.
the point why we started this short case webinar, so that postgraduates can be exposed to teachers all over the state.
Yeah, nice.
Even sir picked up the smallest, that is the main mistake, diminution of vision, the spelling mistake. It is actually, it is very good to notice it, sir.
Yeah.
Definitely they should learn all this.
We should not do basic grammar mistakes.
Yeah, it's very important.
And ophthalmology, sir, pointed out.
Ophthalmology. We didn't note until sir has pointed out.
Yeah, nobody,
didn't-
yeah.
So
Sir,
with
Dr. Rajesh,
this, sir,
Rajesh,
Chairman.
sir, మన participants were just 14.
No, this is only for.
No, this is only for the faculty.
Okay.
This Zoom is only for the faculty.
Faculty.
The rest of the delegates, they'll be seeing it in YouTube live.
Oh, they can
You can't see
in the
that here.
YouTube line. Okay.
Yeah.
Okay, that's the reason you said 600 people.
It's a different link that we have shared to the delegates.
Okay.
Okay, right.
Thank you.
So I think with this, we'll conclude today's APOS ERC short cases webinar, the second session, second episode. I sincerely thank our moderator, Dr. Narasimha Garu, and our dynamic examiners, Dr. Dharmaraju and Dr. Bharani Kumar Reddy. My congratulations to Dr. Vaishnavi and Dr. Sheikh Shazia. And also thanks to Dr. Saujanya and Dr. Gandhar Reddy for mentoring them, for putting them in a proper, for giving them proper guidance. I sincerely thank all my ARC members, Dr. Tarkeshwar Rao, Dr. Nivedita, Dr. Kailan Raju, Dr. Meher Tej, Dr. Kansu, and Dr. Sirisha for actively bringing up this short case webinar and making it lively and useful for all the postgraduates in the state. Thank you very much. We'll meet again next Friday, next January. Last Friday comes on 24th. No, 23rd. So we'll be meeting again for on 23rd January, 8 p.m. to 9 p.m. for the next session, next episode of the APOS ERC short cases webinar. Thank you very much. Good night.
Thank you, sir. Good night.
Thank you. Good night.
Examiners for this particular nice presentation. Thank you.
Thank you.
Thank you, sir.
Service PG. She was in 4th grade. She did surgery. After 3 cases for end of the mood. Sirisha తెలుసు కదా నెల్లూరు.
Thank you. I remember. బాగా గైడ్ చేశారు. Guided your PG nicely.
That's right. Yes, sir.
Right.
Well done.
Good.
Congrats.
Thank you, sir.
Sir, good evening, sir. Good evening, sir. Well done, sir. Well done.
హాయ్ రాజు. నా దాంట్లో కొంచెం అంత డిస్టర్బెన్స్ వచ్చింది, కొద్దిగా అంతా కూడా కనెక్ట్ కాలే సరిగా. బాగా గైడ్ చేశారు. గైడెడ్ యువర్ పీజీ వెరీ నైస్లీ.
మీ గైడెన్స్ వల్ల
రియలీ షీ వాస్ వెరీ కాన్ఫిడెంట్.
వెరీ కాన్ఫిడెంట్. Just shut up. Okay, sir.
Realize